Hello everyone. Next, let us discuss malaria. As far as malaria is concerned, it's one of the most common clinical condition that we encountered in medicine or even pediatrics. I will give a small clinical case scenario of a 7-year-old male, 7-year-old boy comes with less than 7 days duration fever, chills and rigor. He has history of passing dark colored urine. This is the same clinical case scenario that has been asked in last year prof exam. On peripheral smear, you got fragmented RBCs. Okay, as of now, you may not be able to correlate these two things that we will see in hematology. Malaria is so common, around our areas, that is in Tamil Nadu, Ramanathapuram, then Tuticorin. All these are endemic to malaria. Fine. So they may give a clinical case scenario of a boy from this region who have the so and so complaint, so and so finding. Then what you should immediately think of? Malaria. Don't think of some other things. Okay, rarest of rarest things. Okay, yes, common thing is malaria. Fine. So with this basic introduction, let us discuss malaria. Again, I am restricting myself only to pathological perspective of malaria, okay, because in detail the various life cycle, everything you can read from microbiology. Fine, because in pathology they will be asking mainly about the morphology, the peripheral smear finding, everything. Again, the peripheral smear finding we will see in case of hemolytic anemias that we will discuss in hematology. Fine. So mainly it is the Plasmodium species. Okay, it is the Plasmodium species which is going to cause malaria. We have lot of Plasmodium species: vivax, ovale, Naulezi and malaria. Out of that, Naulezi has been found in Indonesia, in monkeys. Okay, fine. What is the vector? Yes. What is the vector of Plasmodium? It is the female Anopheles. Female Anopheles mosquito. Female Anopheles mosquito. Okay. Coming into life cycle. The most fatal malaria is going to be caused by falciparum, Plasmodium falciparum. There will be high levels of parasitemia, severe anemia, cerebral symptom, renal failure, pulmonary edema, even death. Cerebral malaria is the cause of death in Plasmodium falciparum. Plasmodium life cycle in humans and mosquitoes. Am I right? Yes. Infectious stage of Plasmodium is called as the sporozoite. The sporozoite is found in the salivary glands of the female mosquito. So when the mosquito takes the blood, the sporozoites will be released in the human blood. Within minutes, it will attach and invade the liver cells by binding with some of the receptors, that is the hepatocyte receptors, for serum proteins like thrombospondin and propyridine. This has been asked, MCQ. Thrombospondin and propyridine. Within liver cell, they multiply, they release something what we call as merozoites. What are merozoites? They are the asexual haploid forms, merozoites. And as a result of this infection, what happens? The hepatocyte ruptures. And this rupture occurs within 8 to 12 weeks in Plasmodium falciparum. But Plasmodium vivax and ovale, they won't cause the rupture of hepatocyte, but they remain latent within the hepatocyte and they cause relapse of malaria after the initial infection. Weeks and years after the initial infection, they cause relapse. So relapse is seen with the vivax and ovale, and those dormant merozoites within the hepatocytes, we call it as hypnozoites. What is that? Hypnozoites. So the liver infection merozoites, hypnozoites. All these is what we call as exoerythrocytic stage. Why exoerythrocytic? Because all these developmental stages takes place outside the RBC. Asymptomatic disease. Once released from the liver, these merozoites will bind to sialic acid residues, which is present on the glycophorin on the surface of RBC. They penetrate the RBC. Within the RBC, they will mature. They will secrete lot of enzyme. Fine. And they get converted to what we call it as trophozoites. This is what we call it as erythrocytic stage. Okay. Yes. And these trophozoites will further undergo clumping. Many trophozoites, they form what we call it as zygote. Okay. Yes. Then what will happen? The RBC ruptures. These all will be, merozoites will be released into the blood. It is the release of merozoites in the blood which is responsible for fever. Fever is mainly because of TNF, tumor necrosis factor. Depending upon the type of species, this paroxysms of fever, usually it is 48 to 72 hours in case of falciparum. And what is the reason for the fever? Release of merozoites in the blood. Fine? Yes. Then these merozoites, they transform into sexual forms. Merozoites are asexual form. They transform into sexual forms. We call it as gametocytes. These gametocytes will be again picked up by the mosquito. This mosquito will further infect the other human beings. Fine. So this is the life cycle. See, what is the receptor? Thrombospondin receptor. Okay. Yes. Merozoites. They bind with sialic acid binding protein, glycophorin, trophozoites. Finally, multiple chromatin mass we call as zygote. Remember, this zygote is mainly attached to CD36. CD36. Okay, on the vascular endothelial cells. Very, very important. Receptors they may ask. So this is the pathology. When merozoites are released into the blood, what will happen? Fever set. 48 to 72 hours. Paroxysms of fever. Okay, several bouts of episodes of fever you can observe. Remember, Plasmodium falciparum will infect RBC, leading to clumping of RBC. We call it as rosette formation. Rosette formation. Then they stick to endothelial cells, causing sequestration of the endothelial cells, which will reduce the blood flow. One of the most important protein which helps for all of this is Plasmodium falciparum erythrocyte membrane protein 1. They bind to ligands like CD36, I have told you, thrombospondin, ICAM, BCAM, E-selectin. All you know, all these are responsible for vascular permeability. Am I right? Yes. So what will happen? All this will leads to ischemia. Ischemia, because they leads to what? Because of this, all the endothelial cells will what? Contract. There will be no space for tissue perfusion. So there will be decreased tissue perfusion, ischemia. And this ischemia which is responsible for what? Cerebral malaria, which is the major cause of death. I have also told you that Plasmodium falciparum will anchor to glycophorins on the RBCs. Am I right? Yes. And this will further induce cytokine production like TNF, tumor necrosis factor, interferon gamma, interleukin 1. All this will cause fever. Then it will stimulate the expression of reactive nitrogen species, which leads to tissue damage, sequestration. Sequestration mainly due to Plasmodium falciparum erythrocyte membrane protein 1. Fine? Yes. Several type of mutations has known to be protective for malaria. What are they? They will ask this. Number one, point mutation, sickle cell hemoglobin, HBC hemoglobin. Number 2, alpha beta thalassemia. Number 3, G6PD deficiency. Number 4, Duffy group. Duffy group means if the Duffy group is negative, if the Duffy group is not present, they will be protective against Plasmodium vivax, because Plasmodium vivax enter the RBC by binding to the Duffy blood group antigen. Fine? Yes. So these are the most important things regarding the life cycle and the pathogenesis. Remember PFEMP1, CD36, ICAM, BCAM selecting. Okay, yes. MCQ purpose. So coming into morphology, as far as diagnostic test is concerned, we have to go for MGG, May Grunwald Jimsa. We have another one stain that is called as JSB, Jashwant Singh Bhattacharya stain, okay, or Jimsa. Okay, and we usually prepare two types of smear. One is thick smear and another one is thin smear. Fine. In peripheral blood smear, we can see the asexual stages of parasite. Okay, yes. Okay. See, this is another one is field stain. Field stain is mainly used in case of mass screening. Okay, we are going to screen some 1,000 people at a time. We will use field stain. Another one stain is called as right stain. I am going to write all this. Field stain, right stain, MGG, May Grunwald, Jimsa, JSB, Jashwant Singh Bhattacharya. Okay, these are some of the stains. Fine. See, what is this? Duck's granuloma, cerebral malaria. What is this? Duck's granuloma, cerebral malaria. Okay, yes. So I told you it will cause us splenomegaly. As far as morphology is concerned, malaria causes splenomegaly. Fever with the hepatosplenomegaly is one of the characteristic feature of malaria. There will be congestion, hyperplasia of the red pulp. Fine. Spleen become increasingly fibrotic. Okay. And the parenchyma will be grey or black. Yes. Why? Because of hemozoin pigmentation. Then liver becomes enlarged. Kupffer cells will be laden, filled with the malarial pigment. Then coming to cerebral malaria. In cerebral malaria, the brain vessels will be plugged. See, this is the brain vessel. These are plugged with the cerebral malarial parasite. Fine. There will be hemorrhages. All these together we call it as malarial granuloma or Duck's granuloma. Finally, there will be ischemia, cause of death. So these are some of the most important, and of course, it may also causes DIC, disseminated intravascular coagulation in immunocompromised patients, and it may causes what? Severe death. Okay, sorry, sudden death. What is the treatment? Chloroquine, antimalarials. Okay, there is a specific regimen you can read from pharmacology. Yes, that is the regimen we follow only in northeastern states and in other states of the India. Okay, we have two regimens, one for northeast and another for rest of the states in India. Then a word about babesiosis. In babesiosis, you can see the organism in the form of characteristic Maltese cross. What is this called as? Maltese cross appearance. Maltese cross appearance. There is no hemozoin pigments. It is most commonly caused by Babesia microti and Babesia divergens. Ticks. It's not mosquito. Ticks are the vectors, and there is no hemozoin pigmentation. Whereas in malaria, you can see hemozoin pigment. Okay, that is how you have to differentiate babesiosis from malaria. Okay, yes. Okay, so I think with that we have finished malaria. I have just they may ask us a short note question. You have to just but the life cycle, everything in detail you are reading from micro, you can manage with that. Okay, as far as path is concerned, just splenomegaly. Remember, splenomegaly, hepatomegaly, what is Duck's granuloma. So these are the important points you have to write. Then remember the pathogenesis. Okay, CD36, PFEMP1, ICAM, BCAM, selectins, glycophorin, thrombospondin receptors, all those things. Fine. These are because they will ask only pathogenesis. Pathogenesis won't be described this much in detail in microbiology textbook. That is why I am discussing that in detail. That is pathogenesis of malaria. Rest are clinical features, types. Okay, what are the different species? How will you identify? How will you differentiate them? Okay, investigations, treatment, everything you can read from micro and pharm. Okay, yes. Then please remember these 4 conditions which provide protection from malaria. Okay, remember Duffy for Plasmodium vivax. If Duffy is absent, protection from Plasmodium vivax, not Falciparum falciparum. Rest of other are mainly for Plasmodium falciparum. Fine. Remember the stain: May Grunwald Jimsa, right field JSB, Jashwant Singh Bhattacharya. Fine. Then babesiosis, Maltese cross. There will be no hemozoin. Okay. This is how you have to differentiate it from malaria. So I hope this session has been useful. Thank you.